So Sue will introduce herself and moderate this conversation. But I'm really excited to have all of the speakers who you've heard so far today, although obviously you're going to hear from more and their team is a lot larger. But I've asked them to speak on their perspectives on the role of people with PSP, CBD, and MSA and care partners in the multidisciplinary team, and specifically around how teams can help you all build your plans of care and prioritize different recommendations. Sue Reichwein is a social worker as well, by discipline, as well as the manager of clinical and research programs at Penn Medicine, and a colleague of mine for many, many years, and it's so fun to be able to continue to collaborate with her. So Sue and everyone, thank you so much.
Okay, thanks everybody. Do you have, I can chat with these guys, but I also want to make sure that we have lots of questions. Maybe the one thing to start with that would be of interest to all of you, which we didn't really talk a whole lot about today, but how do you all, I guess in particular for the clinic and for therapy, how do you engage care partners in this? Because they're a very important part of people staying well with these diseases and, supporting. So I'm curious, Dr. Deik, can you talk about what the role of the care partner is in the COPE clinic or how they're engaged?
Yeah, absolutely. Thanks, Jen. I mean, you guys already know this, but I think the wellness of our patients really is dependent on the wellness of their care partners. And I can't stress how important it is for you as a care partner to be in a state of well-being, to be able to provide that care to your loved one. And I think we're sensitive to the fact that these diseases are difficult to manage, and that sometimes things like depression and anxiety can ensue in both our patients but also our caretakers. So what we try to do is we try to have a dialogue, particularly going back to the COPE clinic. I think we have the option of speaking with both our patients and our caretakers, but also separately, if that's something that our caretakers are interested in. And really just try to understand where they are in this process, and what's their understanding of the disease and how they're coping with everything that's happening. Of course, caretakers are not our patients per se, but that doesn't mean that we could not recommend resources that they can find helpful to really help your loved one along the way. One of those resources I think that we're fortunate enough to have at Penn, which Sue manages, is a counseling service which we offer to both our patients and our caretakers. And sometimes patients will come with their loved ones to the sessions, but sometimes caretakers and patients will see our counselors independently. And I think there's a lot to be said for asking help and letting everybody know that we are here for you, and you as a family, not you as a patient. We really try to take care of the whole family if we can. And of course, there's limited time when we have our clinic visits, but I think that's the benefit of having these ancillary services that allow to have a more profound conversation and really exploring into whatever issues that are affecting your life. So just know that these resources are available, and if you are a caretaker and you're feeling particularly stressed, just don't be shy to reach out. I would really encourage everybody to ask for help.
And you are going to hear more about that this afternoon from our social worker who really does a lot of work with care partners. But I was always struck with the therapy team because when I put the schedule together for COPE, we would try to peel the care partners off to meet with them while the therapy team was meeting with the person with PSP or MSA, and I always got a hard no. We want care partners to be sitting in and observing and watching what's going on, which really sort of impressed upon me, again, kind of the team dynamic. Do you want to speak to that? Because you were the one that gave me the hard no.
So the way we do the COPE clinic is that physical therapy and occupational therapy, we do a co-evaluation together. And the nice thing about that is we come at it from two different perspectives. So we're asking some similar questions, but sometimes different questions. And if we get a taste of someone who wants to know something or share something personal, it's very easy for me to say, okay, we're gonna go do the gait portion. We're gonna test someone with their balance. And while I'm with that person, the occupational therapist can talk to the care partner. So there is some privacy there if they want that and they wanna talk to us. But most of the time, the care partners really wanna be there, I think twofold. One, the educational component that Dr. Deik talked about. What is this disease? What can I expect? Is this normal? The way my loved one is walking, the way he's always falling, is this part of the disease process? The other thing is that oftentimes care partners, unfortunately, are under the thought process that their loved one is going to be able to remember everything they've told them. They're going to do everything just like they told them. And we know that that doesn't happen in a basic marriage just to begin with, right? And then we add in a disease process on top of that. And sometimes the care partner can feel very frustrated. Well, I've told John when I leave the room, he needs to stay in that chair. Well, John keeps getting out of the chair and moving. And it comes into our role in PT and OT to say, this is part of the disease, that he's not able to remember that you need to cue him for that. And maybe we need to think of new ways for him to be more comfortable so that he doesn't want to get up. The second part of that is that care partners want to be with us because they want to learn how to help their loved one get up safely from a chair, get up from the floor if they have a fall, how to get out of bed, how to get out of the car. And I think it's also great because you might be asking the person with the atypical if this is a problem and they're going like this and the loved one is going, oh yes it is, right? Have you seen that before? So it's better to have those two heads than one because then we really get the real deal. Because sometimes people don't want to admit that they're having trouble or maybe they just don't realize that it is a problem. So that team approach, we do a tremendous amount of education with care partners in prepping them for what's going on now and prepping them for what's to come.
Dr. Irwin, you clinically obviously have a lot of these same conversations, but how about engaging people in research and, kind of that family dynamic of people that are looking out for the best interest of their loved ones? Is there something special or is there a way that you approach that to kind of make it comfortable for people?
Sure, that's a great point. I just want to echo what Dr. Deik and Heather have said, is that it's really important to create a support network and not to be alone and have that support. And the FTD Center, we have a patient and family conference every year. I have caregivers for patients who have more of the cognitive features of PSP and other related disorders, and those are online to see, but people's candid reports of how they built a team, how they approach family and friends. Learning how to ask for help, I think, is a very difficult thing to learn how to do potentially, and how that can be so important to help keep the balance. And in terms of research and our approach to discussing research, observational research, while there's no direct benefit to patients, it does advance science. It's not for everyone. For those who are interested, it does give an opportunity to be a part of a team, interact with our team, getting to see me or our associated clinicians more frequently, potentially in doing part of the assessments, and being part of the science can be, I think for those who are interested in that, can be very therapeutic and can be a very positive experience. And it's just so critical for working towards these therapies.
Hang on to that mic because I got another question.
Along those lines, you alluded to on your slides that a lot of what you've learned through research has been through brain donation. Not an easy topic to talk about when you have people in your office. Can you walk us through the importance of it and how you kind of approach going forward with asking for brain donation?
Sure. So in the state of Pennsylvania, but also New Jersey and most states, the consent process, or the actual getting consent for brain donation, happens at the time of expiration. So any discussions that happen during life are not binding. And we usually have the discussion early because of the importance, and talking with patients, families, and often other family members, because making sure everyone's on the same page and knowing what to expect. Then for those patients who are enrolled in our research program, a major obstacle to brain donation is partially funding. There's a global and national problem. So it's wonderful the work that CurePSP is doing, with the Mayo Clinic to help make brain donation available to those who aren't a part of research studies. Most outside of that, most brain donation is usually in the context of a funded project, so collecting data during patients during life, which then part of that project is the brain tissue and validating, developing new tests from the tissue itself. So this is, so at Penn, our brain donation is part of those, available to those who are enrolled in research, but autopsy is available to anyone who's seen clinically at Penn, so you don't have to be part of research to get a final pathological diagnosis by a pathologist. So at the time of expiration, the final consent is performed by me or one of my close colleagues at the next of kin to confirm that brain donation is something that patients, families want to pursue. And then the research program pays for the transportation of the body, the harvesting of the tissue is done in a way that's sensitive to almost all forms of funeral practices. And that tissue then is analyzed carefully by a team of neuropathologists. A formal report is generated. That can take a few months for the pathologist to go through all the microscope slides and get a final diagnosis, and that's sent to families. And then I call and we discuss the results and the interpretation and answer any questions. And then the tissue, the data, all of that is part of NIH-funded work that helps throughout the world and is shared anonymously to accelerate research. So I have an overview of the process and just how important it is.
And I would also add that it's something that needs to be done preemptively. I feel just awful when I get a call from a family member who says, you know, my dad or my mom or my husband or wife passed away and we want to donate the brain, but it's somebody that we've never had any contact with. And it's sort of heartbreaking to say, well, you know, at Penn we can't take this precious gift, but then we have to kind of start looking around for you know, other opportunities that might be a little more cumbersome. So, you know, it's important to start the process early, so it's not kind of something that you're doing in the midst of, you know, a lot of other things that you're trying to take care of at that time. Dr. Deik, I was interested in, you know, the remote clinic versus the in-person clinic, and of course with telehealth, it's brought medicine a lot closer to people. But curious to know advantages of disadvantages of something like multidisciplinary care in both settings.
Yeah, well, we've all lived through it, right? I mean, for the last 3 years, the world has changed in a way that unfortunately has been very painful, but I think also some unexpected benefits have come out of this, where we now have the ability to really see patients in their home, and licensing and, you know, bureaucratic issues aside, I think there is a benefit of seeing how the patient interacts with their known environment. So it actually can be very informative to see what the space where a patient lives is like and how they navigate that space and how they interact with family members within their home, which is something that we wouldn't necessarily know or see when patients come into the office. And things like medication reconciliation, for example, or going over a list of symptoms is something that really is a conversation. So doesn't necessarily require an inpatient visit. I think a lot of what we can do in the office can be done remotely. And I'm very much an advocate and proponent of telemedicine. Not all though. So for example, there are some maneuvers in our examination that do require us to actually touch the patient. In particularly, I would say there are two. One is to assess tone. Tone is the stiffness that we feel in a patient's limbs. And the other one is to assess balance. So sometimes to assess balance, and I don't know if you've seen this before from your doctors, we sometimes stand behind our patients and give them a slight tap to see how they respond. And that's something that, of course, we cannot do virtually. But those two maneuvers aside, we can really get most of the information that we get in the office through video. And I think between deciding between getting remote care or no care, remote care will always be better than no care. So I think if your loved one is in a situation where they're really homebound, it's important to consider this as an option. Now, in the midst of the pandemic, a lot of the state borders were lifted in the delivery of care, and we didn't really have to worry so much about, well, is your doctor in the same state that you are? Nowadays, that we're at the tail end of this, unfortunately, we do have some restrictions on where we can deliver this care, but my advice in that sense would be to try to see if you can find a specialized movement disorder center within your state or within your vicinity that offers the services that I mentioned that you could.
Your experience with telemedicine, and also, again, how it relates to research, which we know was a whole other thing that we had to tackle through the pandemic.
Yeah, a similar experience. The telemedicine does offer opportunities to connect in ways that may be more difficult, and especially in follow-up visits clinically when mobility may be an issue coming into clinic. And from a research perspective, most of our research activities are done in person because of that important need to collect imaging, biofluids, but we do have some cognitive measures and that can be administered over telemedicine. One of them is digital speech. We can measure all kinds of aspects of speech that can tell us a lot about the brain, and those have been adapted. So as this all develops, the science is following with it too and giving you opportunities, which is great.
So a little bit more hands-on. I'm wondering if I'm going to hear a different story to my left.
Therapists love it or hate it. I'll tell you why we love it, because we can get to rural folks who had never seen a therapist before, folks who never had an opportunity to hear what we had to say before, folks who didn't have transportation to get in. You know, Dr. Deik said we are a challenge to get to and to park at. So from that standpoint, it really broadened our reach to get people out there, which then helped the home care therapists. And then there was a rise in home care therapy, and then there weren't enough of those therapists to go around. The point that we hate it from is we are a very tactile, touchy profession, and we do like to touch people and walk with them and get them up. You can do a lot. Surprisingly, we all learned very quickly what we could do via telehealth. So like Dr. Deik said, I do love to see a person's environment. That's one thing as an outpatient clinician. People will tell me where they are sitting, and they will tell me what their stairs look. But when you actually get that iPad up and you move it around the house and you can see different areas of the house, you can have a really big impact. If I had my druthers, I would love to see everybody in the
clinic. I hope that it does continue. Unfortunately for us as PTs and OTs, we are slated to lose that right through Medicare at the end of December. So whatever you can do to let your local jurisdiction, politicians, CMS, let people know we'd love to still have that ability. Speech pathology will continue to be able to see people virtually, but we may lose that benefit. So stay posted for that.
So, Heather, you had mentioned occupational therapy, speech therapy. I'm guessing that there's a lot of coordinated care, but can you kind of break down a little bit? Because I think people still hear occupational therapy and they think it's going back to work. What a bad name, right, Jules? What a terrible name for something. But I still hear that to this day. So can you describe what the different disciplines are and what they sort of work with?
Yeah, so I'm actually going to put Julia Wood on the spot. Are we able to get Julia a microphone? Thank you. Julia Wood is our former occupational therapist. She now works for the Lewy Body Dementia Association, and she can tell you way better what I can about occupational therapy.
Do you want me to go first?
Go ahead.
So as Suzanne said, if you're wanting to stay at work, that is something we can help with for sure. Basically, as OTs, what we do is try to address the task, the environment, or the activity in some way to help you be able to do it safely and effectively. So we feel that your activities are therapeutic, and that can be from getting up and getting dressed and getting ready to leave your house this morning, all the way to just doing things that are fun, like Heather said, like staying engaged in things that are entertaining for you. So that's what your OT is going to do. Anything you're having trouble with, I encourage you to write it down on a list, talk to your OT, and between PT, speech, and OT, they find a way to knock down those barriers and help you to continue to participate in whatever's meaningful and valuable to you.
Thanks, Julia. The occupational therapists, by and large, have more education and training in cognitive therapy than we do as physical therapists, not to say that we don't work in that realm. The OTs at our center also work a lot in fatigue management, in sleep hygiene. I did mention the pelvic floor therapy. That could be PT or OT. I think most people understand what physical therapists do. One of the things that I like to tell people is we're not just people who specialize in exercise. Our job isn't just to get you to exercise. It's motility, right? It's mobility. So it's any way of helping you to stay active from that standpoint. Whereas our speech language pathologist, it's not just swallowing. Okay, it's also speech. So it is a big issue in the atypicals with problems with swallowing. Our speech therapists talk about, how do you stay active with your speech, because we want functional communication, and that doesn't just have to be verbal. We can use boards, we can use iPads, we can set up Google devices. There are so many amazing ways to stay connected to people from a communication standpoint. There's also the tips and tricks for safe swallowing. Dr. Deik mentioned before that they are the ones who do the assessments for those video swallows. They do a smaller version of a swallow study in the clinic with you, and at least in our clinic, we're all on the same floor, we're all in the same room, so we're all sharing this information as to, this is what I noticed. I was working with Mr. Brown, and he was coughing a lot through this, so I'll let our speech pathologist know this ahead of time. She may say to me, when Mr. Brown came into the room, he almost fell getting out of the chair. And there's different things that we all take away from that. So if you do have the ability to have that interdisciplinary or multidisciplinary care approach, I believe in my core that it is the best. But again, oatmeal is better than no meal. So if you can see one therapist, see one therapist. Don't skip that.
That's a really good point that, when we are together as a team, there's a lot of information sharing that one person may pick up and pass on to another person in their specialty so that, the care is coordinated and, at the end of the day, a plan is created that is in alignment with what everybody witnessed and saw during the clinic. So how about questions from you all? I feel like we've been up here talking a lot. Yes, sir. Here she comes.
Thank you. My loved one is a little further down the road. She is over at Neshaminy Manor. So help me understand the relationship between you guys with the COPE system that you have and working potentially with other facilities. Do you work with other facilities?
Absolutely. I'm sure you know that getting to doctor's appointments and things when somebody's in a facility can be a real bugger.
Yeah.
I'm guessing you've been through that.
Yes.
But we definitely have people that come from long-term care facilities. And then the nice thing about what we can do is generate a plan of care that can be taken back to the people at the facility to be followed.
Okay.
Which I think can be very helpful and very empowering for a family.
Nope, that's great. Second question is, what's the data on how helpful the occupational therapy is for somebody that's more advanced with PSP? How helpful is physical therapy? It took me 90 days to, Lynn went in there last March. It took me 90 days to get them to agree to walk her once a day. And we were able to do that for about 2 months, and now they have taken her off of that because they felt it was too dangerous for them. So, it's a constant battle. Okay, that's my next question. How effective is OT and PT and speech therapy in helping somebody combat these later chapters of PSP?
100% effective, only if they get it. And what you're telling me is not anything that we have not heard. And Julia can attest from her work in Lewy body dementia. There are therapists who say, ooh, I don't want to work with someone with dementia. Ooh, that person's too far gone. That is not good. I don't find it ethical or moral either. There is always something you can do. We have a palliative care clinic. There is always something that therapy can provide. What you can do is go to CMS, that's the Centers for Medicaid and Medicare Services. There are clear instructions on there as to what is covered for therapy services within a home health care setting, an outpatient setting, and direct those therapists to that website. You always have a right to therapy. There is something that is called maintenance therapy. People can be seen. We see a lot of people once a month just to make sure we're keeping base with people and doing things. It's not enough. We're in the outpatient center, so it's a little bit different. But they like to tell you that people have plateaued. Okay? That is a term we do not want to go by anymore, and we really try not to. Just the simple fact of keeping someone from getting worse and preventing them from fall is a goal with people with atypicals. Yeah.
Honestly, I've made myself a major pain in the ass at that facility.
Please do.
Because I completely disagree with the philosophy of, great, you've plateaued, so you're done with PT,
Yeah.
you're done with OT. And it's like, you're missing the point here.
Exactly.
This is a progressive disease, and
Yeah.
so you got to fight the progress. And they say, well, because of the way Medicaid looks at this and yada, 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 it's
No,
like
fight it.
pushing,
Be the
pushing
squeaky
uphill
wheel.
every day.
There are advocates, and I'm going to forget the name, maybe it's an ombudsman. And those are people who know the rules, know the laws, they advocate for you and your loved one on your behalf. But what you're saying is not unheard of, and it's terrible to hear.
How do you get in touch with them, Ombudsman?
I'm guessing that Lauren will probably have that information maybe, but they're posted on the Medicare website, I believe, or the long-term care facilities website.
I can't speak to every state, but I know that in North Carolina, they're usually through area agencies on aging.
Yeah.
Every area agency on aging should have a long-term care ombudsman.
Right.
And there's no such thing as the safety of the therapist. That's ridiculous. We're trained, licensed professionals who can do our job, and if they can't, they probably shouldn't be working there.
Yeah, and you mentioned the palliative care clinic. I mean, we just started this clinic for people with end-stage Parkinson's disease. And, we even were sort of guilty of like, well, maybe therapy is aggressive. And after 2 clinics, we were like, this is ridiculous. There's so much that can be done just in a different kind of way. It doesn't have to be aggressive, but keeping someone from falling, keeping somebody active so that they're not getting bed sores. The swallowing piece of this, which, as you know, becomes worsened and needs to be attended to. So I'm sorry you have to be such a strong advocate, but that's the reality of a lot of long-term care.
Hi, this is for Dr. Irwin. Are there clinical trials for PSP or?
Yeah, so that's a very good question. There is clinical trials. So clinicaltrials.gov is a great resource to look for all the available clinical trials in the U.S. for PSP and related disorder. Dr. Golby could probably comment too about a lot of clinical trials in development. There's a lot of interest. There's national efforts to put together different types of trials, such as what's called a platform trial, to try to make trials more efficient so that multiple therapies are tested together, meaning not in the same patient together, but groups of patients. So I guess let me rephrase this. A placebo group is an important part of clinical trials because we have to see an effect, but we want the way trials are designed is the lowest number of people statistically needed to have an exposure to a placebo rather than a treatment trial are calculated. And most trials have an open label where at the end of the trial, everyone gets the treatment until the trial either meets its endpoints or is closed. So now newer trials are being developed that will start to use the same placebo group and be paired together so that if a trial is midway and starts to show that it's not reaching its endpoints, we could stop it early and go to the next therapy to try to accelerate. So there's a lot in this area, and it's coming quickly. At Penn, we don't have a trial for PSP that's open to enrollment. We have one that's closed to enrollment, but we're in discussions for a few on the horizon within the next year or so. And our website has our updates, and I'm always happy to chat offline for anyone who's interested.
You had mentioned family support. You guys are very much about support for the family as well. Can you maybe add more to that? How can we help our fathers caring for for our mother around the clock? I mean, he has someone during the day who helps out, but he's up all night taking her to the bathroom. What else do you have in mind as far as supporting the family?
So does your dad, does he ever ask you for help, or is he, oh no, my kids have a life of their own, I don't want to burden them?
I mean, geography is a problem because they live far away.
Oh, okay.
But he's not one to ask for help, so.
Yeah, it's hard when you're at a distance because you can't actually stop by on the way home, or say, Dad, go out and I can sit with Mom for the afternoon. I think being more of an emotional support, probably at that point, is important, or also maybe taking things off of his plate that you can do from a distance. Are there things that you can help with, maybe making some phone calls, or helping out remotely with taking care of the books, or getting a care manager involved. There are geriatric care managers that can also sort of help run the show, but it is hard at a distance. I think at that point it's more just checking in and supporting him and making sure that has somebody that he can sort of talk to, and because I think as a care partner, what I hear a lot is that this can be very lonely. Sometimes you lose the person that you've been living with for a long time, and sometimes you lose that opportunity to have a conversation. So, that is even something that can be really significant, is, reaching out and having that conversation, and being there for your dad. And then certainly if you can to visit, making sure that you have that time together, or that he has the opportunity to, take care of his health appointments and things like that, bundled up. It's hard from a distance.
I think a lot of times people think of home health aides just during the day, and the issue with your dad not sleeping, it might be that you need someone who's there at night rather than during the day. And don't discount asking friends, asking neighbors, volunteer organizations, house of worship, therapy programs. A lot of PT, OT, and speech and nursing students do volunteer work for those kinds of things. In this area, we have a program now it used to be called Temple Timeout. Now I think it's us and Drexel. And it's a timeout program where it's a very nominal fee. I think it's like $8 an hour, where a student will come and stay with your loved one while that care partner can leave to take care of appointments or grocery shopping or play a round of golf or do whatever they need to. But if your dad is not sleeping, he's not going to be able to take care of himself or her. So sleep is a critical issue, whatever you can do to help with that.
To be fair, he never slept before, so.
Oh, and then, years of living come into play. Absolutely, yeah.
I echo everything that was just shared, and I also want to share something that I've definitely learned about since joining, really helping to facilitate one of our support groups, one of our national, international support groups. We have a number of people, especially in the Care Partners group and the group that's for anyone who's impacted by any of these diseases. So we have people with the diagnosis, we have friends, we have spouses, we have adult children. I've noticed there's a lot of people who attend from multiple areas in the same family. So we've had some adult children who live in one state, and then their parent from a different state attends at the same time. So it's like they're in that support group together, and it's a really nice way to connect to the larger community and kind of learn things and share similar experiences. So I think that's a nice opportunity too.
Suggestions from, I learn more than anything from when I'm sitting on a support group and I hear of a resource or a suggestion. So I think you can share that even across borders, what helps. I think that's a really important message, Jess. I had two thoughts before we close, and one is that for those of you that are local, our Veterans Administration has a wonderful Parkinson's and Movement Disorder Center at the VA in West Philadelphia. I would urge any of you who might be veterans out there to take advantage of the VA, the PADRAC, it's called at the VA, because you can get a lot of services. You know, there are more things that are becoming service connected. We talked about, you know, environmental things that might be seeing these things, and the government is recognizing things like Agent Orange. So if you are a veteran, I can certainly give you that information for the PADRAC. And I also wanted to point to the importance of nonprofit organizations and advocacy organizations like CurePSP. When Doctor was mentioning the Delaware clinic, the Telemed clinic, the infrastructure at Delaware, the startup money, the seed money, was provided by a Parkinson's organization in our community called the Parkinson Council. And that may not have gotten off the ground without that seed money. So I just really want to, again, highlight the importance of advocacy organizations who can be very critical in getting some of these really innovative programs off the ground, some research initiatives off the ground. So again, thank you all for being here today and being a part of this and joining CurePSP on this day.
Thank you all so much. And thank you all for your great, great questions. I look forward to continuing to learn from your team. We're going to hear from other members of their team, as well as some people with the diagnosis and care partners after lunch. Thank you all. Yay.